he's going to focus more on the specific regional techniques for the battlefield.
Thank you, Dr. Silverman. Thank you, Dr. Lipnick, for inviting me here. Most of you know that this was a very historic weekend. Yesterday marked the 50th anniversary since Neil Armstrong actually stepped foot on the lunar surface. It's a remarkable time in America back 50 years ago. Many of you, however, don't recognize the other incredible landmark event which occurred during this weekend. In fact, today marks the 60th anniversary of the birth of Dr. Sanford Silverman. So I'd like you all to please render a round of applause for Dr. Silverman. Happy birthday to you, Sandy. Happy birthday to you, Sandy.
Wow.
Happy birthday, Dr. Silverman. Happy birthday to you.
All right. Yeah.
I have, besides that, no other disclosures today. And Dr. Danjal did a remarkable job of setting the table for us and for me in terms of what are the anesthetic techniques which could be useful on the battlefield. I've never served in the United States military. I've had some interactions, of course, with trauma, having served as the chairman of trauma anesthesia at the Cook County Hospital for many years, which is its own unique little war zone, as many of you know. I think what Dr. Danjal said really sets the table. We know about the inflammatory response which occurs with trauma. And in the old days, the inflammatory response was vital to healing because it led to immobilization. But we've come to realize that mobilization is critically important, not immobilization. And so, as we've gone through the genesis and the metamorphosis of how we manage trauma, battlefield trauma and otherwise, we know that we've got to get people up and mobilize. We've got to abolish this inflammatory response. So the goals of military anesthesia and battlefield trauma are how do we abolish not only pain and stress and inflammation, but how do we reduce the chances of individuals developing phenomena including phantom limb pain and complex regional pain syndrome. So when we have a tissue damage, we have the release of algogenic substances which cause activation of nociceptors of A delta and C fibers. A delta, of course, being sharp type pain, C fibers being more dull pain. And we have tools in our armamentarium. You've heard Dr. Danjal talk about some of these. Opioids, non-steroidal anti-inflammatory drugs. But local anesthetics are actually at the forefront of combating not only the stress response and pain, but also the inflammatory response. And they help to limit segmental and suprasegmental reflex responses. And you also heard some discussion about tactical combat casualty care. Well, this 2 years ago, it had its 20th anniversary. And what this is it's a look at the events which has really markedly reduced morbidity, mortality on the battlefield. Regional anesthesia is one of the major contributors to this incredible effort which has led to a reduction in morbidity, mortality. The acute and chronic pain on the battlefield, lessons learned from the point of care, injury, to transport of these injured individuals to the States shows that advances in regional anesthesia and the pain management task force have been uniquely suited to this, to helping our wounded soldiers get back to the States and prevent long-term sequelae, including things like phantom limb pain, complex regional pain syndrome. Well, I owe a great deal debt of gratitude, as many of us in this room do, to Chester Tripp Buckenmeyer III. He was the leader and very instrumental in creating the Military Advanced Regional Anesthesia and Analgesia Handbook, also known as MARA. The first iteration of this was 2008, and Tripp, along with Lisa Bleckner, created a wonderful handbook which can actually be downloaded gratis from the internet. So I encourage all of you who have an interest in regional anesthesia to avail yourself of this handbook. I've known Tripp for about 20 years, and he and I had a mutual godfather, that being the great Professor Alan P. Winnie. There's Dr. Winnie with Tripp. At the first MARA convention or meeting, which was held in 2005, and this has become a huge impetus for how we could potentially offer injured individuals regional anesthesia on the battlefield. My contributions are very humble and limited, but I did create the entire modules of upper extremity regional anesthesia for the second iteration of the MARA handbook, which will soon be available to you gratis on the internet. I wrote all the chapters on upper extremity neuroanatomy, brachial plexus block, cervical plexus block, etc. However, even knowing that we have this great reference available to us, by and large, the injured soldiers still are provided general anesthesia to a much greater extent than they are provided regional anesthesia. 71% of injuries are treated with general anesthesia and a mere 13% with regional. I want to go through a couple of quick vignettes. Again, my experience is in the civilian theater, not in the military theater, but I think that we've learned great lessons from the individuals who've learned to treat injuries on the battlefield to prevent things like phantom limb pain, complex regional pain syndrome. So chest wall injuries can be penetrating or non-penetrating. We know that rib fractures are the most common injury associated with chest wall injuries. We know that if you have a fracture of one or more ribs in one or more locations, you can get a flail chest. And flail chests, of course, interfere with ventilation. Ventilation becomes impaired. So how do we treat that? Well, the best way to treat that is with a continuous thoracic epidural analgesic. And of course, we know that the mortality increases exponentially as you have 6 or more fractures of the ribs. We also know that the first 4 fractures, ribs being fractured, will lead to great instability of ventilatory parameters. So thoracic epidural analgesia is the #1 modality for managing not only the pain and disability associated with multiple segmental rib fractures, but also improves ventilatory parameters to a greater extent than any other regional anesthetic technique. After thoracic epidural continuous catheter analgesia, we have continuous thoracic paravertebral blocks, and these are segmental blocks. And we know that these are things which can and are implemented in the battlefield to minimize pain, improve functionality, and reduce ventilatory inefficiency. So after thoracic epidural analgesia, continuous thoracic paravertebral blocks, and then of course we should never underestimate that even doing intercostal nerve blocks may in many cases suffice. And the reason why this is important on the battlefield is because we have these portable ultrasound machines which have great resiliency. You can drop them, you can kick them, sometimes you can shoot them with a bullet, and yet and still they maintain their integrity. So intercostal nerve blocks are useful, and again, the one limitation is to minimize the risk of pneumothorax. We can see the external and internal intercostal muscles and the innermost intercostal muscle using ultrasound. But importantly, we can see the intercostal artery. We recognize that there's a relationship between the vein, the intercostal vein, intercostal artery, and the intercostal nerve. Just by finding the artery, we can safely and successfully perform multiple segmental intercostal nerve blocks. Interpleural catheters are an underutilized modality, and many of us who are older in the room did learn how to perform interpleural catheters. It's best when you position these catheters at the midpoint of the rib fractures. However, thoracostomy tubes, which are typically placed in tandem with these interpleural catheters, can often suck the local anesthetic away from the wound area, limiting the effectiveness, which is why we should limit suctioning for at least 15 to 30 minutes after a regional block has been performed, and we can utilize things like 0.5% bupivacaine in large volumes. This is a multiple segmental intercostal nerve block after all, and this is a rendition of an actual injured person who has both thoracostomy tubes as well as interpleural catheters. Epidural analgesia is the mainstay, however, and I think Dr. Danjal pointed that out very nicely in looking at some GYN data, but it's also true in injured trauma victims as well. It's important that we recognize that we maintain pulmonary toiletry and aggressive pulmonary functioning to minimize things like atelectasis and worsening of ventilatory parameters. Typical agents are 16th percent bupivacaine with opioids given as a bolus dose and a continual infusion. And so why do we use epidural analgesia for major thoracic trauma? Because epidural analgesia reduces mortality by 1/3. It reduces deep venous thrombosis, pulmonary embolization, the requirements for blood transfusion, pneumonia, and respiratory depression. And we use a combination of local anesthetics as well as opioids. Opioids are very effective in the epidural space by blocking at 3 distinct sites: lamina 1, or the marginal zone, lamina 2, or the substantia gelatinosa, and lamina 5, where we find the wide dynamic range neurons. So we block the marginal cells, we block the stalk cells found at the substantia gelatinosa, and we block the wide dynamic range neurons. And so there's some synergy between local anesthetics and opioids, especially for things like dull pain at the C fibers. We know local anesthetics and morphine or other opioids are uniquely effective at blocking dull pain. For sharper pain and for blocking A alpha, A beta, and other fibers, including the sympathetic nervous system, local anesthetics are the best agent, and they are the foundation for regional anesthesia in the battlefield and elsewhere. So this is an epidural. You can place an epidural catheter. It can be maintained in place successfully for hours, days, weeks, or even months. We have opioids which are very effective as well when added to our, as an adjunct to our regional anesthetic techniques. Morphine being the prototypical analgesia in the epidural space, working by a spinal mechanism, whereas some of the lipophilic opioids are useful by working via a supraspinal mechanism. The local anesthetics, of course, by virtue of their sympathetic blocking effect, also improve the rheology of blood and also improve oxygen delivery, which is so essential to healing damaged tissues. The placement of our epidural catheter should be at the epicenter of pain, with great care and consideration being given to the dermatomal areas which subserve that pain, and then placing our catheters at the epicenter. The opioids which are useful in the epidural space, again being hydrophilic or lipophilic, are delivered based not upon weight, not upon size, but based upon age. And there are many studies in the literature that demonstrate that we ought to be administering our opioids in the epidural space based upon the age of the recipient. There are 7 adjuncts which have been safely studied to be very effective when added to local anesthetics and opioids in the epidural space: clonidine, ketamine, epinephrine, midazolam, droperidol, neostigmine, naloxone, and that'll be in your handout if you have an interest in this. What about continuous regional anesthetic techniques? Again, we could use 16% bupivacaine. We can add adjuncts such as buprenorphine, which I've spent a considerable part of my career studying. Buprenorphine, first used by Eric Viel in France, is a very wonderful adjunct to local anesthetics for reducing the concentration and dose of local anesthetics, or clonidine, which has been studied extensively as well. So let's look about some of these extremity injuries. Again, one of our focuses about the timely implementation of regional block is to minimize or reduce the possibility of patients developing things like phantom limb pain and complex regional pain syndrome type 2. Is this a real phenomenon? Well, any individual who sustains a traumatic amputation is going to have phantom symptoms, and in a larger percentage with upper extremity amputations, traumatically, you're going to have phantom limb pain, not phantom symptoms, but the actual sequelae which persists, compared to about 50% of individuals who have sustained a traumatic lower extremity injury. So continuous lumbar epidural analgesia is very effective for preventing the NMDA receptor changes, which we know which occurs in the face of a traumatic event. So extremity wounds in the military, how do we treat these? Typically with epidurals or peripheral nerve blocks. And again, our goal is to improve pain, reduce pain, improve functionality, and also provide a mechanism or substrate for providing higher levels of oxygen to these injured tissues. Upper extremity injuries, brachial plexus block, go back to that MARA handbook, which was created by Dr. Buckenmeyer. Crush injuries, again, are prone to the development of complex regional pain syndrome type 2, where there's an actual neural injury, and we treat that using continuous epidurals, continuous brachial plexus, or continuous sciatic nerve blocks. These photos are from the battlefield, courtesy of Dr. Buckenmeyer, and you can see a supraclavicular brachial plexus block and catheter, and you can see this is a double upper extremity amputee being treated successfully with bilateral brachial plexus catheters. And this was maintained in place until the injured soldier could be airlifted to Germany for more definitive treatment, and then subsequently airlifted back to the United States of America. These are continuous sciatic nerve blocks and catheters. Again, these are old slides. You can see that these are now 16 years old. But aside from the fact that ultrasound has become a mainstay in conjunction with the use of, for example, neurostimulation, these techniques have not really changed dramatically. Our goal in providing regional anesthesia is to prevent or minimize acute pain changing to chronic. And again, this is determined by the degree of injury, how timely or effectively treatment was rendered, and the patient characteristics. These are soft tissue injuries which always occur following penetrating and oftentimes non-penetrating injuries. We also have to consider abdominal injuries, and how would we treat them in the injured soldier, and consider splenic rupture, liver injuries, and the ventilatory aberrations which occur in light of abdominal injuries. So here are some both civilian in the Iraqi conflict as well as military injuries, and the only significant mechanism or way to use regional anesthesia to effectively block the nociceptive response and improve functionality here would be a continuous thoracic epidural analgesia. I'll finish excuse me, by just briefly mentioning head injury. Head injury is very difficult to treat with regional anesthetic techniques. Of course, we have things like stellate ganglion blocks and continuous cervical epidurals, but by and large, if individuals have sustained head injury, we don't necessarily know using radiographic techniques whether there's been a cervical spine injury. Head and neck injuries, most probably best treated using general anesthetic and systemic opioids until such time as we can provide regional techniques to improve blood flow, things like stellate ganglion blocks. So in conclusion, it's important to treat pain aggressively and early. This is to not only minimize acute pain sequelae, but also to minimize the development of sequelae, including things like complex regional pain syndrome and phantom limb pain. Regional anesthesia should be provided on a continual, not intermittent basis. And that's because we know that the long-term, the quality of life when regional anesthesia has not been used is dismal. Up to 60% of individuals who've sustained a massive trauma will have pain and discomfort persisting for up to 7 years. There'll be reduction in ability to self-care, reduced activity, anxiety, and depression, especially in female victims of trauma, limited autonomy. 74% have a reduction in long-term healthcare quality of life, and severe problems which are persistent. So we need to implement regional anesthesia. In conclusion, the goal is not only to control pain and reduce inflammation. Remember, immobilization is not the goal. Mobilization is the goal, which is why regional anesthesia, especially that which utilizes local anesthetics, is at the forefront on the battlefield for minimizing long-term pain and disability. And I thank you for your time and your attention.